Hey, everybody. It's Kevin, it's Zane, and it's Jonathan, all from RPH Ally. We're super excited to talk to you guys today about something that's really been present in lots of different ways, but we want to bring it back to instead of talking about something that happened way in the future, what can actually we do with some of these things today? How can we make it applicable to take a large language model and artificial intelligence and make our lives better for clinicians and patients? We're going to hit the reel. We'll be right back. All right, man. So good to see your guys' faces. I feel like we get side conversations together. It's nice to bring the posse all into one space. And let's just kind of set the audience, I guess, up well here, Jonathan and Zain. I'll pass it over, Jonathan, you first, to kind of describe what is an LLM? What's a large language model?
Yeah, so a large language model in layman terms is essentially a way where a computer program is able to predict text, chunks of text called tokens, based on the previous token that it saw. So, for example, if you give the computer program a token called Cephab, it's actually going to be two tokens, and then it can predict what comes next. So it could predict Cephab is a cephalospore. That's one prediction. Cephab is dosed renally. That's another prediction. Cephab is used to treat pneumonia. That's another prediction, right? And based on all like the current large language models, the famous ones at least by OpenAI, it's really trained on the whole internet text. So every time that large language model, so Cephab is, right? It knows what comes after, right? And it's now becomes a matter of statistics and prediction to predict what comes next. So if you write Cephab is and you click generate, it essentially gives you the next token and based on what's in the whole internet. So, and that comes with pros and cons, obviously, because it's not trained on something that is legitimate or scientific. It's just the whole internet. Some of it is useful, some of it is legitimate, but some of it could be just a blog post by a random person, right? And that's why sometimes large language models hallucinate by themselves, and that's why we can. It's good to have guardrails and kind of knows how it could be very useful to us. What are some guardrails, and what is the limitations of these models?
That's super interesting. And Zain, what do you think when it comes to applications of large language models? You and I have talked about it a little bit in previous shows on like how we can use some AI to be able to do some predictive analytics and be able to fill in some gaps that we may need, or just maybe make us more efficient. When it comes to actually using these models in particular, what are your thoughts on being able to train them inside of healthcare and be able to use them for our subject for the day, drug references?
Yeah, so large, like, I can't really add to what he said, but they're trained on data, right? So the internet's data, and a lot of times, I mean, Jonathan, you can correct me if I'm wrong. They're not really trained really well on medical data yet, right? Because you're looking at Wikipedia, Google, Facebook. That's where all these language models are being treated. They're not really being trained on like academic like stuff right now, right? And that's one thing that's kind of stopping them from being used in healthcare. But one way you can do that is physically give them the documents to train. So for example, like for drug references, you can upload the whole drug reference, have it index it, and then have it work off that. So your large language model is only using that as a reference for all the answers moving forward. So that's one way, but then it's not as smart as, let's say, like the big ones like GPT-4 or whatever. But it's a good way to at least get the conversation started, get people used to it, and then hopefully, as people, I think one of the biggest things is like people are just scared of it, like they don't really understand, like it's not 100% right. You don't know what kind of answer. He talked about them hallucinating on their own. So like I think it's just like we have to take baby steps moving forward, and then and this is kind of like you can maybe start with like an FAQ, right? FAQ type situation where you have a bunch of these drug references in there. And then this is the way I would envision using it is you have all these drug references, you're a hospital system or a clinic or whatever, you upload this drug reference or drug references, you create a chatbot for your patients or whoever that they can ask like, hey, what are the side effects for this? Or how do I take this medication? Do I take it with food? Do I not take it with food? Like things like that. Like, so really, really simple, like like yes no type questions, and then start from there, and then work your way up from there, and saving like the clinicians time for questions that are relatively easy in terms for us to kind of like, we would have to look them up regardless, and they can just the patient can kind of take care of themselves as they're moving forward.
Yeah, I think just to kind of disrupt the industry kind of conversation we can have here is looking at some of the major drug databases that are out there and looking at some of the major drug information resources that have been out there. They've been around longer than I even knew what a pharmacist was, right? I mean, they've had the same kinds of data, they've had the same kind of input, they have the same kind of infrastructure, and they're very, maybe pervasive is the wrong word to say, but they're highly ubiquitous. You just see them everywhere in every setting using these exact same companies. When it comes to the data sets they were pulling in previously, like this, it was a major differentiator. They were able to pull in large amounts of data, compile them inside of their systems, and then redistribute them to electronic health records or wherever the case was. Do we think, Jonathan, that because of these large language models, that we'll be able to see other players come in and disrupt that market?
Yeah, I mean, this might sound extreme, but I've been in this technology for like 3 years now. I really feel that all these drug companies, if they don't change how they're doing things now, they're going to become obsolete. So you said how I talked about LLMs and the limitations of LLMs, large language models, but you can go solve these limitations very easily by using semantic search, right? And we kind of use AI as this big word that means like a million things, but it's actually just like in pharmacy. There's like oncology pharmacy, there is ICU pharmacy, there's retail pharmacy, and there's completely different ways of working. So it's the same with AI. And one of the fields is semantic search. And what semantic search is, this is really how Google works nowadays, is you say, um, you know, we'll stick with Cefabime. You say, for example, Cefabime dosing, right? So that semantic search goes through the whole internet, unbolts the documents, right? Or the web pages or whatever it may be, where that dosing that is relevant to the question that you're asking, right? And this technology is not that new. It works very, very well. Everybody uses Google. Everybody kind of, yes, it becomes worse now, but it's not because of technology choices. It's more of, Google choices. But the technology works pretty great. You say Cefabime dosing, it will pull a relevant link to you very quickly, right? And this is a type of AI, nothing new there. If you combine that AI semantic search with the large language model, where you get a right document, legitimate, agreed upon source of truth, right? When you ask like 50 people, 49 of them would say, yeah, this is a good reference, right? And then you feed that to the large language models. All of the sudden, you basically don't have these limitations anymore, right? It cannot hallucinate because it's only looking at the document that you gave it to, right? It cannot go up completely outside that document because, again, very easily through the prompting and some other techniques, you can say, hey, if the answer is not there, just say, I do not know, right? So basically, you combine semantic search with the large language model, and all of the sudden, you really have an amazing tool that you can look at all the drug information out there, right? Bold the relevant parts to your question, and give you the answer in a human-friendly way. And so, yeah, so the old model, if it's like, hey, we're gonna write a 2,000 word document, and you as the clinician have to go in and basically dig through, right? I do think that is a very, very dangerous assumption to think it's going to stay the same way in the next 5 years or so.
Wow. No, I love it, Jonathan. I mean, you and I had a pretty in-depth conversation on this exact same topic a little while ago. And I think that when it comes to pulling in that data, Zane, when it comes to sources of information, one thing that as a clinician, I've always thought was interesting is the fact that you and I have talked about having 1,000 tabs pulled up because we've got to look at all these different sources and then be able to compile them together and make an informed decision based on data points. When it comes to some of the innovation that I just read about just the other day was Epic. So Epic is looking to, I'm not downgrading any company. So Epic, this is a plug for, yes, I'm glad you're doing this. Related to them trying to have more integration with other EHRs, which, typically and classically, they've even admitted to this, they're known that they are closing everything down. But the one thing that they said they were trying to have more integration with was this: variants. variants in genetic variants so that they could start pulling in those variants from one system to another, and that the variants of an individual patient could follow them around their healthcare journey. Zane, are there other like pieces that you feel like are going to be integral to us really updating these drug references using things like AI and LM, other than like CPIC guidelines, PharmGKB, to be able to fill some of those gaps in that we may not have already?
I mean, I think that, I'll be honest, I don't really understand the question you just asked.
This is fair. I will re-ask it. So the question is really this: when it comes to like, okay, Epic is allowing for more
Yeah.
variants, right, to go across the model. We're talking about making a more robust and feeding a large language model using AI to be able to give us the correct answers back. What other things do you feel like historically or classically a lot of these drug references have not been able to give you, that you have to go to outside sources to be able to validate or update yourself with, that you look for the large language models helping in the future?
I think it depends on what reference you're using, right? I think for the most part, in the clinical world, I mean, the only things, I mean, I shouldn't say the only things, but like one of the questions that really does come up quite a bit is compatibility, right? Is it compatible with this? So those are multiple references that you have to kind of bring together. So, it'd be great if you could, nurses always calling pharmacy like, hey, does this compatible? It'd be great if they just had a dashboard like, hey, is Vanco compatible with Zosyn? And it would just tell them yes or no, right? And so that's one thing. The other thing is like, excursion data. So, but this one would be a little hard to get because a lot of times, if people don't know it, excursion data meaning like if something's been left out of the recommended temperature range for longer than it was supposed to, usually drug companies on the package inserts will give you the most conservative numbers. But if you call them, they'll tell you like, hey, it's this, this, and this, right? You can actually do it for this, or hey, you left it out for a day, you can throw it back in the fridge, it's still good for 30 days, or something, things like that. So that would be another great thing if you can get excursion data, but then there's like legal things that the drug companies have to do. There's a reason why they don't put that in the package insert. So I think for the most part, the drug references we have, you just would need to combine a couple of them together. And then the things that we can't get to are usually like legal hurdles that already exist right now. So it wouldn't be like the large language model that would be fixing it. We would need a bigger conversation as to, hey, can we get a reference or something, or some sort of API where we can just plug into Pfizer, Merck, or whatever, that your internal documents, and only doctors or pharmacists will have access to it, right? Something like that, to just kind of mitigate some of the risk. But that's kind of what we would need to do first to even get to that point.
Yeah, but I'm going to tell you something, Zain. I think I fell into this trap too, right? That we kind of have so low standards in how we work and how the user experience should be and how efficient things that we should be, that a lot of us think, oh yeah, it's good enough right now that I have to spend 15 minutes, right, finding out a super simple question by the current drug references. That's just how our brains got trained, right? But if you think about it, the generation coming up, they're not used to this, and they're used to the experience. You literally have a search box and you type whatever in ChatGPT and it gives you an answer right now, right? Why would you spend 15 minutes, 20 minutes digging through like the traditional sources of information while you can get an answer in 5 seconds, right?
Oh yeah, no, I meant to say I was just answering his question in the sense that, is there something missing that we would have to put into this large language model?
Yeah.
Maybe I misunderstood the question again, but I think that would be amazing. I think we need that, right? Like, when you're in a busy clinic or a busy, like I remember like working in clinic and you just get a sidebar like, hey, can you look at these medications? Do they interact with each other? Or hey, what is the alternative to this medication and this and that? Like, that takes some time. That takes like 15, 20, half hour long. But if I could just type in like, hey, does this medication interact with this, or what is an alternative medication to this? Because honestly, guys, anyone who's listening, that doesn't make you a bad pharmacist. You don't need to memorize every single drug in the world. No one knows everything. You have to look stuff up. All right, I'm just gonna get that out there. Maybe I'm a terrible pharmacist because I didn't really know much of anything, but I looked at everything all the time. But what I'm saying is that would be amazing. I think so. That's what I meant. Like, I think we would have to combine. There's all the information exists. It just needs to be combined into one thing. So if we can combine it into one, take like UpToDate and Lexicomp and take the whatever Trissels, I think it's called, merge them into one thing, and then you can just ask it like a Google search. and and then a lot of times these large language models, you can it's usually like they'll tell you exactly where it got it from, right? So like it's from this part of the document, or it's this. You can have it reference things, right? So if you don't trust it, or somebody doesn't trust you, and that's also another thing too, right? Like, hey, if a doctor's asking you for like a paper or some sort of if you're looking for some sort of
A reference.
reference, thank you, I can't talk.
Yeah.
That's another way. That's another place where these large language models could be amazing. Like, hey, give me, how many studies have there been on, Herceptin use in colon cancer, and boom, it'll just give it to you. So you're not like going through PubMed and trying to figure out the perfect query and all that stuff.
Yeah. This is exactly, to me, the perfect use case, is that all this information exists out already. It's not really super organized, right? It's not super clear. It takes us 15 to 20 minutes to look through it right now. Just crunch that down to 5 seconds, right?
Mm-hmm.
And the value, and I said that sometime, I said the value of a good pharmacist actually is knowing how to ask the right question. Like me and Kevin were talking the other day, and he's like, "Hey, what's the alternative for metformin as a first line for diabetes?" Remember that, Kevin?
Yep.
Right? And then the large language model told him the alternative is this, right? But that's not the right question. The right question is, why are you not using metformin, right? And that's what you alluded to, Kevin, right? And that's why these technologies would never replace anybody, because if you're a good pharmacist, if someone comes to you is like, "Hey, I cannot use metformin as a first line in diabetes," you want to ask, why cannot you use metformin? Is it because of a GI side effect, right? Is it, what's the reason? And then you can have this discussion, and this is exactly why, like, us pharmacists are so valuable.
Yeah, and that's kind of like akin to like cars, right? Like before we walk everywhere, then then they domesticated the horse, then they put a cart at the back of the horse, then multiple people would be on the horse, then the car came, and now we have buses, trains, planes. Like they're all achieving the same thing, but you still, all they're doing is just getting you to the place faster, right? That's all
Leads
it's
to
doing.
efficiency.
And so that's the thing, like the purpose of it is still the same. It's just going from one place to the other, but it's just getting there faster. It's not replacing. And these planes aren't flying by themselves without humans inside of them, right? I think that's
Yeah.
like, you need us still to pay for that. And then, you brought up a great point. I think that's the one thing that I think people that have never not practiced in clinical medicine kind of overlook, is that that intellectual piece of it, like like asking the right questions. Why are we doing this? The why part of it is something that the LLMs, at least right now, and maybe even because you kind of have to be a little bit sentient at that point, right?
Yeah.
And
You're
that's
never
not,
going to be able to replace that. They
yeah,
will answer your questions very clearly, right? And they do
yeah,
now, but they would never come on that clinical judgment of saying, "Hey, this guy creating clearance for using Zosan and Vanco, it's because you're using Zosan and Vanco," right? It will give you the adjustment very easily, right? But it would not make these connections and ask, like, and tell you this is the question that you should be asking, essentially. And this
yeah.
is really all clinical judgment.
And that's the thing. Like maybe I mean, I hate using this term, but people say, "Oh, we used to know all this stuff when we just knew it off the top of our head. I could subtract and multiply and divide all at once." But yeah, a calculator is still faster, right?
Yes,
And
exactly.
I can get that grunt, not, I shouldn't say grunt work, but I can get like that initial grunt work done. So I can. What makes us special, right, as humans, is our creativity and our mind, right? If we're releasing the computational part of it, which can be taken care of by other things, then our creativity will flourish even more. So to me, like that's how we should be looking at it. Like, how can we become better pharmacists by utilizing these tools, or doctor or whatever? Because now you have more time to diagnose. Now you have more time to talk to the patient, really get into the weeds of their home life and their financial life, all that stuff. Like right now we don't have time because we're searching Lexicomp or Up to Date for like, hey, how do we treat this, or what's the what do we do when this person's creatinine spikes, right? Like, I mean, like the information is already out there. It doesn't, some people know it, a lot of people don't. That's not what makes you great. It's what you do with that information after you find it out.
Yeah.
Yeah. You guys both are going around the exact same thing of just the real skill is asking good questions, like, and knowing how to ask good questions. And I think those good questions is really our next question. Is we talked about LLM and how it can make a superior drug reference, right? By incorporating all these sources and pulling into one place and feeding it the information that only will allow it to give us the clinical data back that we should be getting, as opposed to it hallucinating. But I think the next piece for me is as these models are coming out, which are very rapid, there are some that are out there already that I think pretty good. But with these coming out, what's the next stage for pharmacists and healthcare practitioners when it comes to really leveraging these today, getting good at using them today? Like what, in my mind, like where do I go first with asking that question is exactly going back to what Zain and Jonathan were just saying when they're talking about how do you ask the right question so that the model will give you back the answer you really want, as opposed to just asking a random question and giving you an answer and you spewing it to a patient. That's not serving anybody, and that's not utilizing your degree whatsoever. And so I think that element of knowing how to ask good questions brings me back to grade school of going, how do you use Google? Like, how do you do a Google search? How do you look at these elements? And I think that's the training in my mind that clinicians are going to need to go through rather quickly to be able to understand and leverage these models. But I'm sure I'm missing a lot of things, and you guys can fill in other gaps. Zane, I'll go to you first, buddy. What other things do you think we could do to get up to date on this?
I mean, the thing is just trying it, right? A lot of these models are still free. You can go on OpenAI, Perplexity, Hugging Face Chat. I mean, there's like a gazillion of them right now, right? Just type in large language model chatbot or something, and you'll get a bunch of them, and just go in there and just start asking it questions, and and then there, look up prompt engineering, right? Just Google prompt engineering and what is like how to engineer a prompt, because that's kind of going back to like humans asking the right questions to each other. To use these properly and to get the right information that you want, you need to ask it the proper question and kind of direct it in a way where you need it to go to. So I would just say, man, the best way to learn is just by doing it. And just do it. Just log in. All the accounts are free, and just play around with it. And worst case scenario, you're like, oh man, this sucks. This thing is stupid, right? I mean, that's worst case scenario. Best case scenario, like, oh my god, this is amazing. There's a lot of awesome no code applications out there. Maybe you can create your own chatbot or whatever, and make your life a little easier, right? For your practice, for you personally, whatever. Like, but the only way you're going to know any of it is by just trying it. Like, I've always been a person that don't believe the hype on anything, right? Just unless I physically do it myself. Yes, there's a lot of people talking about it. You and Jonathan and I are talking about it. You're like, don't even listen to us. Just go out and try it, and you'll be either surprised or disappointed. But you decide what you want to do.
The one thing I love about that prompt there, Zane, is that we always talked about Dr. Google, right? We had patients coming in or their family members coming in saying, this is what they found in Google search. Well, Google just got a lot better through LLMs and chats and a lot more evidence-based, let's say, to a certain degree. So when they're coming in with their questions or their quandaries, oftentimes it could be closer to the truth. And so us having a better idea of what they're looking at, why they're looking at it, how they're feeding answers is going to make us better clinicians to answer those questions. So I love that you hit on that. Jonathan, what do you have to add on to that, buddy?
No, I mean, I think Zain put it perfectly. There's no substitution for actually trying things out. And the only thing I would say is it's early, right? It's very, very early. So if you're trying things out, you're an early adopter, right? And historically, 5% of the population is early adopters, 95% are not, right? And the people who are early adopter they get like a reward by being the first person to use it and having all these things for free and having all these tools available for them, right? Like back 3 years ago, you can buy a Tesla, you can get the self-auto pilot, for like $3,000. Now it's like almost 20 or 15 or something like that. So there is a reward for being an early adopter. But if you're an early adopter, you have to understand things are going to improve super fast, right?
Mhm.
If you go in there and you're like, oh, I don't have a great experience right now, come back in 3 months, right? And use the same tool because it'll be so much better. And like, I am personally fortunate. I was actually one of the first people to use GPT-2, which is open source, right? And it was like, whatever, like 80% accuracy, right? Then GPT-3 came out. I was like 90%, right? And then GPT-4 came out, and now it's like 95%. And then you add a semantic search, layer on top of GPT-4, and now it's like 99.9%, right? And it's going to continue to improve. And so again, as an early adopter, you have to try things, right? And you have to kind of keep an open mind and saying, okay, this is the future, right? I have to get comfortable with it, even if I don't become an expert. And it just, things will take time for everybody to get used to things, especially a lot of these tools are new. So
I love it. Yeah, I think the validation element is kind of now, right? Us being able to use it, validate it, be able to double check it. And Zane and I talked about this in a previous episode, Jonathan, and I know you agree. is having an expert like you, the folks that are watching this, go and use it. Like, you're going to know, is it spewing out things that you feel like are inaccurate or not necessarily aligned with the question you were intending to ask, as opposed to your patients who are already using it. Let's be perfectly honest, already using it for their medical quandaries and not knowing what that information is giving them back exactly. And so I think it puts more pressure on us as healthcare providers to say, what are you doing for your health and where are you getting your information? Maybe even more important today than it ever has been before, because now, Dr. Google just ended up getting a degree because he passed a medical exam, just recently, and the NAPLEX, right, Jonathan? So
Yeah.
those pieces, I think, are pretty big for us to be able to jump into. I'm going to turn it back to you guys for any parting words, though. I'll start with you, Jonathan, on any parting words for the audience, buddy, on encouragement. With our title was LLM and AI and drug references and policies. We danced around it, but any parting words?
Yeah, so I mean, first part about that patient thing, actually, I think we're overestimating how much it will be useful for patients, because the greatest skill is being able to ask question. And I've seen this personally when a patient comes in and says, "Hey, I have water on my ear. What should I do?" Right? And the answer is not that great. Versus if you actually go in and use the medical term, right, it gives you like a great answer. So it would help. There's definitely an improvement for the current sources now, but like I think overall, we're overestimating how much usefulness it will be to patients. In my opinion, I might be wrong. Yeah, but then other than that, like I said, the best advice is, just use it. It's a cool tool. I think we're lucky being in that generation. um, there's a lot of productivities that are going to get unlocked, and we'll be able to pursue things that previous generations were not able to pursue. So
Love it. Zain, what do you have for us, bud? If that is Zain, if that's a robot, we're still not
Yeah,
sure.
I was just gonna say I need to, LLMs are great, and we need to make them all. No, I mean, I think Jonathan said it best. Like, I think we're in an exciting time. I think, not I think, but sensationalization of everything happens because of clicks and stuff, and I really do think that people are missing out on something amazing. Kind of what John, not everyone is an early adopter, but if you are, it's a really amazing time to be part of this. And and also, if you get into it early enough, you have the opportunity to dictate the way these tools are being used in your practice, in your homes, everywhere. So if you are truly scared of it, right, that should drive you to use this more and understand it more and see what it can and cannot do, and then drive it, and then kind of carve out exactly how it's going to be used, because all these companies have all these models and they're all looking for use cases right now, right? And if you can give them good use cases and be like, hey, that's what they're going to go towards, that's where they're going to divert themselves towards. So that's what I tell people, is like, that's why you need to be involved in this right now. You might not think that you're smart or whatever, what are you going to do? But if you start creating compelling use cases and people around you are like, oh yeah, that's awesome, and then it just kind of snowballs, that's what all these companies are going to start doing, because in the end, money matters, and they're going to go towards where all the money is.
yeah, I
Totally.
cannot
Yeah,
agree more, Zane.
that's perfectly said. And I think that's one funny thing we don't always recognize, is there's a lot of innovation happening, and to be able to capitalize on that innovation for your patients, for your institutions, for your own businesses, it only takes a couple clicks here and there. I know that one place you can go is you can go check out Zane's channel, Digital Thoughts. So you can go check out all the cool things that Jonathan is building and getting taken care of on Galen. And then you can go over to RPH Ally, head to rphally.com, join the Healthcare Tech channel. And both these cool guys are on there. Ask them any questions that you kind of want and pushing the profession kind of forward. I know Zain is working on some really cool open source kind of components. And we're trying to push Jonathan into that space with us too. So we'll get the conversation going. Last nugget is, we've got a big RPH Ally first ever community event coming up, the RPH Ally Soiree, happening the 18th through the 20th. So get those dancing shoes on and ready to party. We've got over 20 thought leaders throughout the US. I'm super humbled that they are joining us to talk about everything kind of happening clinically and the future of pharmacy. So it should be a lot of fun. And thank you guys both for jumping on today and talking about all this nerdy stuff. I always love it, and we'll have to do it again sometime soon.
Thank you.
All right, guys. Have a good one.
You too. Have a good night.
Bye-bye.